Hello everyone. In today's video, we will discuss about unmasking the cause for hypersensitivity pneumonitis. I'm Dr. Sakir Navi Siddiqui, one of the respiratory consultants here in James Cook University Hospital in the UK. Also happen to be the service lead for ILD and bronchitis services. So why does it have so much of an importance here to identify the cause or triggers for HP? A, because HP is often mistaken for idiopathic lung fibrosis. Although there are distinct patterns, the distinct CT patterns between an IPF and an HP, but often chronic fibrotic HP can be mistaken for IPF. Previously, we used to classify HP as acute, subacute, and chronic, but these days it's either inflammatory or fibrotic HP. And the fibrotic HP on CT often is mistaken as IPF. And the reason behind its importance is IPF does not have a trigger, but HP, since it has a trigger, if you can remove the trigger early, the disease can actually be cured or reversed. So today's key clinical insight would be look into the history, dive very deep in the history, because the patient might feel, oh, it's just one bird that I have, oh, it's just a small damp patch or a mold at home. How can it cause such devastation within the lungs? And often we tend to miss the key elements in the history which triggers an HP. So you might end up treating a patient with steroids and other immunomodulators or immunosuppressant, but find the patient is not improving, rather progressing, because you never identified the right triggers. So the key is in careful, targeted questioning. So here we will discuss about the 5 commonly missed causes for HP. The most common cause is the bedroom exposure. You end up asking the patient, oh, do you have a bird or a pet or a bougie or a parrot? And they would often say no. And then you just move on from HP. That's not true. We need to dive slightly deeper here. We need to ask the source of feathers like in pillows or duvets. So they might not have a bird, might not have a parrot or a bougie, but they might be sleeping on pillows and duvets which are filled with feathers. So we need to ask them, what's inside your pillow? Is it a foam, cotton, or feathers? And often the clue is their symptoms get worse in early hours in the morning after being exposed to the feathers throughout the night. Secondly is the bathroom exposure. We need to ask them about hot tubs, about sauna, about poorly cleaned showers, because those are a source for mycobacterial antigens. Often you do end up finding more ground glassy and small nodular appearance in the CT, but I will give that a bit of a less focus because HP in general will have ground glassy appearance, especially the inflammatory type. Then we need to ask them about indirect exposure to bird. They might not have a bird or a parrot or a bougie at home. They might not have feather pillows or duvets at home, but their neighbors might have birds and they are just exposed to it. So we need to ask them, do you think like your neighbors have a parrot or a bougie or a bird? Then the hidden mold. We must inquire about molds or damp patches at home, any damp spot, any leaks, any unusual smell at home. And lastly, the chemical exposure. We need to ask them about spray paints, insulation materials exposure, because that occupational exposure might be associated with HP. So the smart diagnostic approach would be A, obviously after the history taking, is the CT scan, and we need the expiratory phase here because the inspiratory phase might miss or will miss the air trapping. So when you order a CT for a possible or a suspected HP, you need to order the CT in expiratory phases to look for air trapping alongside the mosaic attenuation. These are features of inflammatory HP, by the way, not fibrotic one. So this is a classic HP in inspiratory phase. Why we can say this is an inspiratory phase? Because you can see here the trachea. This is an inspiratory phase looking trachea here. And what you can see here is some ground glassy and nodular changes affecting the upper portion of the lung on both sides. There is a bit of a mosaic attenuation, but we cannot see much of air trapping here. And then again, when you look into it, a very typical mosaic attenuation pattern for inflammatory HP. So you have got mosaic attenuation here due to the ground glassy changes and some nodules affecting the both lungs. Now this is an expiratory phase, and you can see the difference. We can see a lot of air trapping here and the mosaic attenuation, lots of micronodules here. The reason why we can say this is an expiratory phase is you can have a look at the trachea. That's the shape of an expiratory film trachea. So the classic features of inflammatory HP are air trapping, mosaic attenuation, nodules at the mostly affecting the upper zone of both lung or upper lobe of both lung for that matter. That's the difference between an inspiratory film and an expiratory film. You need to look at the trachea. The trachea is more oval and circular in inspiratory compared to expiratory. And that's the difference, and you can now see how prominent an HP can appear in expiratory film compared to inspiratory. You can still have the suspicion on an inspiratory film because you can see a bit of ground glassy, you can see even a bit of air trapping here in the inspiratory film. But if you look at the expiratory film, it's a major difference there. You can see significant mosaic attenuation, significant air trapping everywhere. So take home message is always request for expiratory phase CT if you are suspecting HP. And that's a fibrotic HP where you have reticulations here. If you look closely, you have reticulations here. So you have that mosaic attenuation on both sides. You have that air trapping there as well. And then on top of it, you have fibrotic HP. The reason it's important and the reason behind the paradigm shift from acute, subacute, chronic to inflammatory and fibrotic HP is if it's an inflammatory HP, all you need to do is give steroids. There is no role of antifibrotic because there is no antifibrotic. You can give other immunosuppressant like MMF or azathioprine later if it becomes steroid refractory or steroid is not completely resolving the CT findings or the symptoms of the patient. But ideally, for inflammatory steroids, inflammatory HP rather, the treatment is always steroids. But if you do see fibrotic changes, then you can start thinking about antifibrotics if there is a progression on the PFT or patient symptoms and also in the CT alongside introduction of MMF. So the second smart diagnostic approach after the expiratory phase CT is lavage. We can take the lavage. There will be high lymphocytes more than 20 to 30%. Strong indicator is more than 40%. Differential for high lymphocytes in lavage is IPF and sarcoidosis. And then obviously what we discussed at the beginning, we need to dive deep in the history, look for the environmental triggers because that's your step A treatment. Irrespective whatever you give to these patients, whether you prescribe steroids, other immunosuppressant, it's not going to work unless you remove the trigger. That is why always dive very deep into the trigger. Treatment for HP, A, B, C, everything is removal from the exposure. Only after that comes steroids or other immunosuppressant. So clinical summary, if the patient has lung fibrosis, air trapping, mosaic attenuation on CT or a high lymphocyte count on lavage, think about chronic HP, not IPF. Management strategy, always A, look for exposure, look for those missing bits of the puzzle that we discussed. Ask them about the feather bedding, ask them about the hidden mole, ask them about the neighbors having birds, ask them about the hot tubs or saunas, ask them about chemical exposure. Treatment approach, as we mentioned, primary is removal of the exposure. We need to get rid of the triggers, and then we can introduce the immunosuppressants depending upon whether it's an inflammatory HP or chronic fibrotic HP. If it's an inflammatory HP, we start with steroids. If it becomes less responsive or unresponsive, we can induce the other immunosuppressives such as MMF or azathioprine. If it becomes steroid refractory as well and you want to taper or wean off steroid, then you can also introduce MMF as well. If it's a fibrotic HP, like we mentioned, if you see mosaic attenuation or air trapping and then on the top of it you notice fibrosis on the CT, then you need to start introducing MMF from the very early stage. And also if there is progression of fibrosis or lung physiology or patient symptom, start antifibrotics. Steroid is not recommended for fibrotic HP, as in fibrotic HP there is no active inflammation, so there is no role of steroid. But if you do see some inflammatory changes, ground glass changes on top of the fibrotic HP due to a flare, then obviously we do prescribe steroids. So take home message today is, if you find mosaic attenuation with air trapping, think of inflammatory HP. If there is some degree of fibrosis there, think of fibrotic HP. Make sure you do request for expiratory film CT in prone position to retrieve the actual findings. Always look for the triggers, look for the hidden triggers and exposures. And in terms of the treatment, the basic principle is, if it's inflammatory, it's steroid. If it's fibrotic, then MMF plus minus antifibrotic depending upon progression. If you want more details in terms of the treatment regime, then please do write in the comment section. I'll make a separate video on it. Thank you so much for listening today.